My name is Francisco Ponce. I'm a P3 student at UT Tyler, Benamidi Fish College of Pharmacy. I'm going to be doing an in-service on cellulitis, and I want my audience to introduce themselves.
Hi, I'm Andrew Lang.
Hi, my name is Ken Marties.
I'm John Ho.
Danny Aguayo.
Hector Garcia.
Okay, let's begin. So I wanted to start with the learning objectives really quick. So what I want you guys to take away from this is to learn the common pathogens that can cause cellulitis, know the diagnostic criteria for cellulitis, know when to treat outpatient versus inpatient, know what classifies the case as complicated, know the treatment for mild, moderate, and severe purulent cellulitis, and know the treatment for mild, moderate, severe, and severe non-purulent cellulitis. I know we've all had, it's been a while since we had ID, but do y'all remember what the two most common pathogens that cause cellulitis are? Staph and strep, yeah, correct. Okay, so the most commonly caused by Staphylococcus aureus or Streptococcus pyogenes, although it can be caused by other bacteria. These other bacteria are going to be either Haemophilus influenzae is the most common cause of periorbital cellulitis in children. Streptococcus galactae is a common pathogen in elderly patients, those with diabetes mellitus or peripheral vascular disease. Staphylococcus aureus is the most common pathogen found in injection drug users, and that will usually be MRSA. And also Pseudomonas aeruginosa is commonly the pathogen when there's a deep tissue from stepping on a nail. So usually diagnosis is not necessary. For most cases, it's just going to require the clinician evaluating the differential diagnosis and evaluating the affected site because most of the time the culture will come back negative and we won't know which agent to use usually. So we have a kind of like a flow chart as to what to use depending on the classification. But if we do require diagnosis like it is with severe infections, the way they usually do it is an injection, an aspiration of 0.5 mLs of saline to the advancing edge of the erythemal lesion, followed by a gram stain. And like I said, gram stain and other tests usually yield a negative result for a microbe, so empiric treatment is usually used. The more severe cultures of the blood and microscopic examination of cutaneous aspirates, biopsies or swabs should be considered for patients with malignancies on chemotherapy, neutropenia, severe cell-mediated immunodeficiency, immersion injuries, and animal bites. Once the offending agent is discovered, empiric therapy should be replaced by defined therapy. All right, so treatment usually differs depend on which cellulitis the patient is diagnosed with, either purulent or non-purulent, and the severity of the infection also is taken into account when deciding treatment. The goal of treatment for acute bacterial cellulitis is to rapidly eliminate the infection and prevent further complications. To treat the inflammation and swelling associated with cellulitis, the affected area should be elevated and immobilized. Also, if you need additional help with the inflammation, prednisone 40 milligrams daily for 7 days could be used to help with the inflammation in patients that are not diabetic. Okay, so managing inpatient versus outpatient. Outpatient therapy is recommended for patients who do not have SIRS, which stands for Systemic Inflammatory Response Syndrome, altered mental status, or hemodynamic instability. Hospitalization is recommended if there's a concern for a deeper or necrotizing infection. Patients with poor adherence to therapy. Infection is a severely immunocompromised patient, or if the outpatient treatment is failing. Now, do y'all remember what the SIRS criteria is? There's a few values.
Like respiratory rate greater than 20.
Yeah, respiratory rate greater than 20.
Temperature less than 36 or greater than 38.
Yeah, temperature less than 36 or greater than 38 degrees Celsius. There's two more. I'll just tell you.
Heart rate greater than 100.
Heart rate greater than 90, and one more. Though it's regarding the white blood cell counts.
Well, I don't remember.
Okay, so less than 4,000 or greater than 12,000 is usually when there's concern for it, and I have that listed here. Okay, so complicated cases occur. Sometimes, and a case is considered complicated if it's severe or extensive disease involving multiple sites, rapid progression of infection, signs and symptoms of systemic illness, complicating factors like elderly comorbidities or immunosuppression, abscesses located in the area that is difficult to drain, such as hands, face, or genitalia, and lack of response to incision and drainage alone. So treating mild purulent cellulitis. Incision and drainage is the primary therapy for all purulent cellulitis. For the mild one, most of the time that is enough to get rid of the infection. But if we are going to be needing antibiotics, you're going to lean one way or another depending if you suspect MSSA or MRSA. For MSSA, we want to use cephalexin, dicloxacillin, or augmentin. For the penicillin allergy, you can use clindamycin oral as well. And then for MRSA, you can use Bactrim, doxycycline, or minocycline. You can combine that with cephalexin or penicillin if streptococci coverage is needed, and if there's a penicillin allergy, you can use clindamycin or linezolid for that one. For treatment of moderate purulent cellulitis, incision and drainage, along with oral antibiotics or IV antibiotics, depending on the serous criteria. So if the serous criterion is just only one applies to the patient, oral agents are issued, and then MSSA suspected is going to be cephalexin, dicloxacillin, or augmentin, and those with penicillin allergies can use clindamycin. For MRSA, if MRSA is suspected, we can use Bactrim, doxycycline, minocycline, and again combine that with cephalexin or penicillin if we need streptococci coverage, and penicillin allergy, again, clindamycin or linezolid. If the serous criteria is 2 or greater, we're going to need IV agents, and the patient's going to need to be hospitalized. For MSSA, those agents will be oxacillin, nafcillin, or cefazolin, and then if they have an allergy to penicillin, it'll be clindamycin. If MRSA is suspected for those, it's going to be vancomycin, clindamycin, or linezolid. For severe purulent cellulitis, incision and drainage, again, but the patient does have to be hospitalized for this one. Culture and sensitivity should be drawn. Usually these patients will have a higher than 2 serous criteria and pretty bad systemic effects. So they could be close to having sepsis or something close to that matter. Usually broad coverage antibiotic therapy is initiated, including vancomycin, clindamycin, linezolid, daptomycin, ceftaroline, telavantin, and tigecycline. If MSSA culture comes back positive, we can change the dose to change the medication. To oxacillin, nafcillin, cefazolin, ceftriaxone, and if there's a penicillin allergy, we can do clindamycin or vancomycin. If the MRSA culture is positive, we will just leave them on the broad coverage antibiotic therapy, as those are the agents we usually use in treating MRSA. As just a flow chart of the different treatments available, kind of just goes over everything. And then for treatment of mild non-purulent cellulitis, usually requires just oral antibiotic agents. We're really using just agents that cover streptococcus here or MSSA. We're not really thinking about MRSA if it's not a significant infection. And it's usually measured if it's systemic or not, if there's systemic side effects or not. So for mild, the agents are going to be cephalexin, dicloxacillin, penicillin VK, or augmentin, and penicillin allergy will be clindamycin. For the treatment of moderate non-purulent cellulitis, treatment choice depends if the patient's serous criteria score. 1 serous criterion, you can use PO. Dose PO therapy, which cephalexin, dicloxacillin, and penicillin VK or augmentin is indicated. Patient has a penicillin allergy, clindamycin. If greater than or equal to 2 serous criteria, we're going to do IV therapy with cefazolin, ceftriaxone, or penicillin G being used, or penicillin allergy, clindamycin. I want you to note here also, we're not suspecting MRSA in this case. It's really just for if there's proof that there's MRSA or if the infection is more severe. And then for severe non-purulent cellulitis, treatment of choice is broad coverage IV antibiotic therapy with vancomycin plus piperacillin/tazobactam, or the carbapenems imipenem or meropenem being used. Probable Streptococcus pyogenes infection and or suspected MSSA, you can use cefazolin, cefotaxime, ceftriaxone, penicillin G, or if they have a penicillin allergy, clindamycin. And then if suspected or known MRSA or treatment failure with the above agents, you can use vancomycin, clindamycin, linezolid, daptomycin, ceftaroline, telavantin, or tetracycline. And this is again just a flow chart of the that you can use when deciding treatment. And these are the agents used along with the dosing, and some comments on the medication itself to be helpful. Okay. And lastly, I want to go over prophylactic treatment. This should be considered for patients that have 3 to 4 episodes a year, and attempts to control as an attempt to control predisposing factors. Prophylaxis should be continued as long as the predisposing factors persist. Prophylactic regimens include penicillin 250 milligrams or 1 gram twice a day, erythromycin 250 milligrams twice a day, decloxacillin 500 milligrams twice a day, clindamycin 150 milligrams daily, and those usually last, the duration of that therapy is usually 2 to 52 weeks, or IM intramuscular benzathine penicillin every 2 to 4 weeks can be used as well. And these are just some references. Now I will open up for questions.
So what are some of the consequences of untreated cellulitis?
Okay, so cellulitis can get pretty bad if it's left untreated. It can go into the bloodstream, cause sepsis or endocarditis, and a number of other infections.
I was wondering, how does cellulitis present?
Usually the area will be hot and painful to the patient, and then as it progresses and gets worse, they'll develop a fever, kind of feel groggy, I guess, would be the term that most patients would use.
How do you classify mild and moderate to severe?
So mild is going to be just the skin infection by itself. Moderate is some systemic side effects are present. And then for the severe, it's usually systemic side effects plus other symptoms like hypotension that the patient is experiencing.
What is the usual duration?
Usual duration is 5 days of treatment, but it can extend longer if the patient isn't responding.
So I guess for like your more advanced like infection, like necrotizing fasciitis, if I need if I have a patient that's allergic to clindamycin, what would you recommend?
If they're allergic to clindamycin and penicillin as well?
Yeah.
Okay. Linezolid would cover pretty much everything that clindamycin does, and if any additional gram-negative coverage is needed, we could use a carbapenem.
Thanks.
So, all right. Thank you, guys.